Dave, can you hear me?
Yes, sir, we can. Thank you.
Okay, thanks.
Ladies and gentlemen, this meeting is now live on the internet. This is the Wednesday, September 23rd, 2020 regular meeting of the Health and Hospital Committee, 2:30 p.m.
Good afternoon, Roshni. Would you like to do a mic check?
Hi.
Hi there. We can hear you. Thank you. Good afternoon, Miguel.
Hi, good afternoon.
We can hear you. Thank you. Good afternoon, Jackie. Would you like to do a mic check?
Good afternoon.
Great, thank you.
You're welcome.
Narinder, would you like to do a mic check? Mr. Press, would you like to do a mic check?
Yes, hello, how are you? Good afternoon.
Great, thank you. Loud and clear.
Thanks.
And Curtis, would you like to do a mic check?
Yes, good afternoon.
Thank you, sir. We can hear you. Good afternoon, Chairperson Simidian.
Good afternoon. Can you hear me loud and clear?
Sure can. Thank you.
Thank you.
Mr. Chair, a quick question before we get started with the meeting. We do have that memo that came in about item number 16. I'm not sure if you wanted me to read the information about that or if you wanted to mention that during the consent calendar item.
Let's split the difference when we get to the consent calendar. I'll ask the clerk to read the memo that we've received on item 16. How's that?
Understood. Thank you, sir.
Thank you. All right, ladies and gentlemen, I think the hour of 2:30 has arrived. We thank you all for being with us today at our County of Santa Clara Health and Hospital Committee meeting. And the first item of business is to call the meeting to order. So let me ask the clerk to call the roll.
Good afternoon. Vice Chairperson Ellenberg
I'm here.
and Chairperson Simidian.
Present.
Thank you. You have a quorum.
Thank you very much. Presence of a quorum having been established, we will move on now to item number 2, which is public comment. Public comment is that portion of our agenda set aside for non-agendized items that are properly within the jurisdiction of the committee. Let me turn to the clerk and ask, do we have any comments under public comment today?
We have no speakers on this item, sir.
Thank you. That takes us to item number 3, which is to approve the consent calendar and any changes to the committee agenda. Supervisor Ellenberg, I understand from the clerk that there is a late breaking development. So let me turn to the clerk and ask what the news is that affects our consent calendar action today.
Thank you, Mr. Chair. On item number 16, per the memo sent to the committee this morning, we have received a request from administration to make a change to item number 16 to delete policy SLRH number 7349222 regarding death pronouncement from the policies submitted for St. Louis Regional Hospital.
Thank you. My understanding is there's some additional work to be done there, and happy to provide the time and opportunity to do that. So if Supervisor Ellenberg is prepared to move approval of the agenda.
Consent calendar.
Thank you. We have a motion and a second. Before we go to a vote, however, I'll ask, do we have speakers on the consent calendar?
We do not, Mr. Chair.
All right. Then I have a motion from Supervisor Ellenberg, a second by Simidian for the record, to approve the consent calendar and changes to the committee agenda, noting that the policy referenced under item 16 is no longer part of the consent calendar. With that understanding, please call the roll.
Vice Chairperson Ellenberg,
Yes.
Chairperson Simidian.
Simidian, yes. Thank you
Thank
very much. All right, that takes us to item number 4, which is to consider recommendations relating to medical staff and the allied health professionals at Santa Clara Valley Medical Center and at O'Connor Hospital and at St. Louis Regional Hospital. This is a monthly event. Let me ask who's here to present on this item today.
Hello, my name is Yvonne Karanis, and I am the Enterprise President of the Medical Staff. I'm here to present the credentials report. In addition, we have on here the addition of some privileges at St. Louis for family practice, internal medicine, and orthopedics. This is to address that physicians now are providing ambulatory care at the DePaul Clinic. And these are ambulatory privileges that we have added for those St. Louis physicians. In addition, I wanted to give the board an update on the Enterprise Committee on Health Equity and Racial Justice that we are working to establish as a medical staff committee. This will be an enterprise-wide committee, obviously as stated in the title of the committee. And we are working to create an interim structure for this committee as our committees live in the medical staff rules. And we are working currently to revise those rules. But while that process is ongoing, we are working to create an interim structure for the committee that will allow it to start operating. In our revised bylaws that are making their way through the approval process, we have designated the chair of this committee to be a voting member of the Enterprise Medical Executive Committee. So if those bylaws are approved, they will be coming to you and you will see that individual and this committee designated on there. We're hopeful that this committee and the chairs will also be collaborating with other initiatives, both in the hospital and the county related to equity and inclusion. Thank you.
Thank you very much for the report, Supervisor Ellenberg. Indeed, as noted, the recommended actions under item 4 are A, B, C, and D that do include the family practice privileges, the internal medicine privileges, and the orthopedic privileges that were just described. Would you like to make a motion to approve the recommended action in item number 4?
I'd like to first just thank Dr. Karanis, and you anticipated my question. I was really very interested to hear a little bit more about the committee and the work that you were doing around race and health disparities. So thank you for preempting that and for offering the update. And with that, I'm happy to make the requested motion.
You're welcome.
All right, thank you. Motion by Ellenberg, second by Simidian. Let me turn to the clerk and ask if we have any public comment on this item.
We do not, sir.
Thank you very much. Then we'll call the roll.
Vice Chairperson Ellenberg
Yes.
and Chairperson Simidian.
Yes.
Thank you.
Item 4 is approved unanimously. Thank you again, Dr. Karanis. Thank you.
Thank you.
That takes us to item number 5, which is to receive the report from the Facilities and Fleet Department in connection with the Santa Clara Valley Medical Center and the Office of the County Executive relating to the Child and Adolescent Psychiatric Facility. This is the Behavioral Health Services Center on the Santa Clara Valley Medical Center campus, scheduled to open fall of 2023. Let me turn to Dr. Smith and/or his staff who'd like to present on this item before I get to my monthly questions.
You got FAF to present initially, and then your question will be answered.
Thank you so much. Is that going to be Mr. Draper or someone else?
This is Jeff Draper from the Facilities and Fleet Department. I'm going to let Doug Koenig, my Deputy Director, report the details on this month's report.
All right, Mr. Koenig, welcome. Thank you.
Thank you. As you can see, we have made some progress here. XL Construction has been selected as the CM at risk. They're currently on board. We've already had our first coordination meeting, kickoff meeting with them, and it looks like we've got a pretty well-rounded team right now.
I would
Thank
like to
you
add,
for that.
I would like to add,
Go ahead, Mr. Draper.
Supervisor Simidian, I'd like to add that XL Construction is currently also doing our Animal Services Center project, and they're ahead of schedule. So we have very positive vibes about this particular project.
Thanks so much. Thoughts this month, gentlemen, about or others about the suite of beds at O'Connor that we've talked about potentially converting to temporary inpatient facility, but with the understanding most recently that it might well not be completed too far in advance of the new facility. Yes? What's your thinking these days, any or all of you?
I would say nothing's changed as we have not been pursuing that option. It may be likely now that the current plan would finish ahead of that.
Thank you. Dr. Smith, any thoughts on whether that is a path worth pursuing or whether we ought to stay focused on the project that is before us?
We talked about it quite a bit, and our best estimate is that the project for the building on the VMC campus is much more likely to be done and satisfactory than it is to convert everything at O'Connor. Converting O'Connor is a lot more complicated than we initially thought it might be because of structures and new codes and a number of other things. So we think we should devote our entire attention to the VMC campus and make sure we get done on schedule and on time.
All right, thank you for that. I'm going to ask some scheduling questions that I know will come as no surprise as I look at packet page 53, page 2 of 4 in the report. The plan was for pre-design to be completed on the project March 2020 and for design to be completed in February of 2021, coming up not that far away, for construction to actually begin February of 2022, and for the facility to be open and functional and open to patients November of 2023. Let me just ask the team here, Mr. Draper, is that still, are we on schedule for all of that still?
We are still on schedule, Supervisor.
Thank you. And Mr. Lorenz, I think you're on the call as well. Could I ask you if it's your understanding that we're still on schedule?
Yes, sir, we are.
Thank you. How about Mr. Koenig, from whom we were hearing just a moment or two ago?
Yes, Supervisor Submitting, we're still on schedule.
Mr. Ohashi, are we still on schedule for those items?
Yes, Supervisor, we are on schedule.
All right. Mr. Sodi, are we still on schedule for those items?
Yes, we are.
Thank you. And Dr. Smith, is that your understanding that we're still on schedule for all of those items?
Yes, it is.
Thank you, Dr. Smith. All right. Thank you for your patience with that exercise, which will continue monthly, as I've indicated. I want to address now one other issue, and I'm going to let my colleague step up on this one first if she wants to, since I've been hogging the microphone on the item so far. Supervisor Ellenberg, you and I had expressed some concerns about entrance, exits, and the separation between and among various clients / patients at the last meeting. Should we just ask the staff to comment on progress made since we talked about this, or do you have specific questions you'd like to walk through? How would you like to proceed, ma'am?
My understanding is that information will be coming to us in October when they have, when they present more of the interior design. I think they're certainly aware of our concerns about the entrances that will be used by kids or teens be welcoming and child-friendly, and I'll look forward to seeing that in October.
All right, Mr. Draper, does that sound like that we're still on track for that particular report back and some progress, perhaps?
It does.
All right, thank you then. Supervisor Ellenberg, anything else on this item?
No, happy to make a motion to accept the report and receive the report.
Thank you. That is the recommended action. I'm happy to second it. And thank everybody, by the way, for keeping the project on track. Much appreciated, truly. Let me just check with the clerk before we go to a roll call vote. Do we have any speakers on this item?
We have no speakers, sir.
All right, thank you then. We have a motion by Supervisor Ellenberg and a second by Supervisor Simidian. Could we call the roll, please, just for the record?
Vice Chairperson Ellenberg.
Yes.
And Chairperson Simidian.
Yes.
Thank you.
And that item is approved unanimously. All right, that takes us to item number 6, the COVID-19 report from Dr. Cody and County Administration. And we did receive a report yesterday, but let me turn to Dr. Cody and the staff and see what, if anything else, you would like to share today.
Hello, Supervisor Simidian and Ellenberg. This is Dr. Cody here. I don't have anything to add to our report from yesterday, but I am happy to answer any questions that you may have about COVID-19 and the county's response.
Thank you. I do have a question / request, but let me go first to Supervisor Ellenberg, see if she has comments or questions. Supervisor,
thank you so much. Yes, I do have a few follow-up questions to the school hearing yesterday, Dr. Cody, and just want to get a little bit more specific than we did yesterday. The state has determined that reporting data on outbreaks and school closures is up to the counties. Can you tell me who, if anyone, will report such data on outbreaks and school closures in Santa Clara County?
So first, I can tell you that outbreaks of any kind anywhere are reportable to us, as I think you know, as well as schools will be reporting any cases that they have in students or staff, so that we can assist them with case and contact investigations and keeping the school safe.
Sure. Let me clarify. I meant reporting to the public.
Okay.
My apologies if I wasn't.
Yeah.
I think I wasn't
so
clear.
If your question is regarding how we would report cases or outbreaks to the public, that's something that we have not landed on a plan as yet.
And when you have landed on a plan, how will you let us know what the plan is?
Well, I think that this is something that we would need to be in discussions with schools about. We would certainly want to protect privacy at the school, et cetera. I will say that the schools, we have provided templates to the schools so that when they have a case on campus, they have templates both to contact the contacts of the case, to provide information, all of that. So all of those reporting templates are available. In other words, it's quite important that those in the school community understand what's happening at their school, and we have provided resources and templates to enable that to happen in a pretty seamless fashion.
It sounded, maybe I misheard. We're protecting the privacy of schools? I obviously understand with regard to individuals, but we wouldn't share that books in elementary or whatever other school has been closed or has had a cluster or an outbreak. I would think that there would be interest and concern more broadly to know that.
Yeah. Well, I'll take that back, because as I said, I don't have a decision or a plan that I can report to you today.
Okay, I will look forward to hearing more on that. Thank you. With Santa Clara County happily moving into the red tier 2 weeks ago, at that time it was stated that the most important and largest element of that reopening was the potential for schools, and that other activities currently prohibited by the county risk reduction order, like indoor dining and worship services, wouldn't move forward yet. In part, of course, to prioritize the school opening. With so many districts delaying reopening through January and some not opening at all this academic year, how will we assess any impact on case rates during this slower rollout and also allow for reopening of additional sectors in the coming months?
Well, first I want to say that we are doing everything that we can to encourage schools to open.
I understand.
Public schools, private schools, charter schools. And we have hopefully struck the right balance in our K through 12 reopening guidance of providing details around what's required, as well as some flexibility allowing for all the differences across campus, as well as stood up a whole schools team of many, many disciplines involved to support schools and help them. And so I just think that is so important to state and to state clearly, is that getting schools open and getting kids back into school is a priority. I think that with a number of private schools opening and some public schools, although less than, of course, we like, we will get some sense of the impact of a school reopening on transmission, particularly in the immediate community. So that's what I can share with you at this point.
Oh, I definitely hear you and understand your goal of seeing them be open, but we do know, I think that's Dr. Day's, Mike, but we know because they've made announcements that some school districts are not going to open, and in particular, I'll call out San Jose Unified because they are the largest school district in San Jose. They've made statements that they're unable to reconcile why indoor businesses like dining can't safely open, but it is safe for schools to resume in-person learning. Can you share what your response would be, or what is to that question, and what additional steps we might be taking in order to assure that schools and teachers feel fully prepared to open?
Yeah, I think, unfortunately, San Jose Unified had not consulted with us in any detail prior to their decision. So I do want to say that. There's not really a comparison between school and indoor dining. We have very specific protocols, requirements, and recommendations for schools, which include use of face coverings, social distancing, ways to improve ventilation, et cetera, to ensure that schools can be safe. And if indoor dining is the comparison, you really, for example, can't keep a face covering on while you're dining. So there are safeguards that cannot be put in place for indoor dining that can be put in place for schools. And another concern that particular school district has raised was, hey, we're looking at the data dashboard and we see that case rates now were what they looked like back in the spring when schools closed. Why is now different? And now is actually quite different for a number of reasons. Chief among them is that we have lots of infrastructure in place that we did not have in the spring. For example, widespread availability of testing, a robust case and contact tracing team, much more community awareness. We didn't have that in place in the spring, and we do now. So it's not really a comparison between that time and this time.
Right, certainly not in our preparedness, but I think what they were comparing was just the actual numbers of cases.
Right, but remember that in the spring, we weren't testing enough to know what our actual numbers were. So, right, we were finding, we didn't have widespread testing. Right. So the proportion of actual cases that we were able to identify in the spring, quite different than now.
So wouldn't that work the other way if we were testing fewer people but still had about the same number of cases? That help me get to why that's a significant difference that should be reassuring rather than concerning. To me, it seems that if we were testing fewer people in the spring and had about the same number of cases, I don't know if our positivity rate was higher then, but the implication that I heard was that our numbers could have been even higher in the spring.
Right. Our positivity rate was higher in the spring. We were not testing as much in the spring, so that the cases that we did find were likely a smaller proportion of the overall cases that existed. Whereas now we're testing much more broadly. We're finding a larger proportion of cases that exist, and the positivity rate is lower. I don't know if that makes sense.
Okay.
So at any rate, but back to the top line is that we are here to support San Jose Unified in opening, as we are here to support any school in opening. And we have made our guidelines and our tools as clear and helpful as we possibly can.
Great, thank you. I have one more school-related question, but this is really about after-school programs, and among the after-school programs, kids gymnastics is one sector that I know you as well as I have heard much about. Currently, they're restricted to 10% capacity, yet had not one single outbreak when they were fully open all summer long, operating as a camp. Can you share what we're doing first to address this specific sector and related after-school recreation activities for kids? What I'm looking at is changing the designation from camp to after-school activity, obviously doesn't alter the physical safety of the activity.
Right. So as you may know, this particular example of children's gymnastics falls under the state's guidance. And so we actually did clarify, is children's gymnastics considered an after-school program, or does it fall under the gym guidance? And they clarified with us that it is considered a gym program. And so that's why it falls under that. So it's not a locally imposed requirement. It comes from the state guidance. It's one of those odd betwixt and between examples.
So that's an example of where the state has a stricter standard than we do under our, if we get to the orange tier, is that something that would be open, or it still somehow depends on the state?
I haven't looked at that. I'd have to get back to you on that about what the change would be in the orange tier. Don't know that off the top of my head.
Okay, thank you. I would like to request that information back. Two of the large studios that have been very vocal and active are in my district, and I know that they would be very grateful to have that information.
Of course.
Thank you. I'm going to switch just a couple more questions now on custody settings. To my knowledge, just one site visit has occurred at each of our county custody facilities to inspect and recommend corrective actions. Do you know what mechanisms are being utilized either by you, Dr. Cody, or your deputies, and on what schedule to actually ensure that social distancing, masking, and other COVID preventative measures in custody settings are being followed?
Sure. I think that Key Lee is on the line and is probably in the best place to answer the custody questions. I will say that our department, one of our member of our health officer team, actually has been out twice to each site, is the best of my understanding, with the exception of James Ranch, where I think they've just been able to visit once. I don't know if Key is on the line and can jump in here. Key, are you on the line?
Let me jump in for a second. Key is with me, and just for the subcommittee's information, I think I might have said it once at a board meeting, but didn't emphasize it. Keely's new deputy county executive, and I've asked him to coordinate issues related to custody, probation, custody health, and the sheriff regarding our COVID response, because as you well know, those different agencies all interact with the jail in different ways with different responsibilities. And we wanted to make sure that we have a centralized figure in the administration that can keep track of the details. So Key can answer your questions and I'll turn it over to him.
Sure, but before Key, thanks Key, just give me 1 second because I want to clarify a little bit there too. What I'm looking for, and I am glad that you are the point person, but specifically, has a consistent deputy or assistant health officer been designated to conduct those inspections or consult on preventative measures to support consistency for the custody settings? So that's something I assume you would be organizing or convening, but not doing yourself.
Yes, we do have a member of our health officer team who is the point person for all things related to custody, Dr. George Hahn, and he has some folks that he works with. So he is the public health department point person.
Okay, I would like to request at our next committee meeting, if it's agreeable to the chair, that we get a report on the inspections, the consulting, the dates, when they're happening, what preventative measures are being put in place. And is it Key or Dr. Hahn or someone else who's responsible for assuring that the corrective actions are taken in response to public health orders?
The depends on the particular corrective action that you're talking about. Key is responsible for keeping track and coordinating. The responses or parts of the response related to sheriff's deputies and staff is actually under the authority of the sheriff. The physical plant issues, which have all been addressed, are under the authority of the county executive. And probation obviously is responsible for the personnel at the ranch and in juvenile hall.
Well, we have now active external enforcement for, that have been sending notices of violations and inspecting places. I would think that that enforcement team or public health in some way overrides the authority of the sheriff if in fact there is any conflict in much the way that the public health officer has authority over enforcement in the rest of the county. Why would it be different because it's under the sheriff's department or purview?
Mostly because it's part of the county. So the enforcement agency, the DA and county council who do enforcement for restaurants and other parts of the community use a punitive approach by using notices of violation and fines and penalties.
Right.
Since we have an administrative structure within the county where we can theoretically control the operations of the jail and probation under the authority of an executive and administrative management team, we use that structure instead.
So what's our recourse if the inspections reveal that the safety protocols are not being adhered to?
You mean if the sheriff didn't respond to our request to adhere to protocols?
Yes, or we just see in actuality that they're not being adhered to regardless of what the official policy is?
Well, maybe county council will answer this more clearly than I can, but in order to forcibly compel a separately independent elected official to comply with a policy, I think you probably have to go to court. But we would certainly avoid that.
Sure.
We think
So
that
Is it Doug that's going to answer that?
Yeah, I can. So as you've probably heard from us saying things along these lines in the past, things that involve the jails, compliance issues, non-compliance issues, because we are under 2 consent decrees, there are additional layers of enforcement in the form of opposing counsel, class counsel for the plaintiffs, which are all inmates in the jails, as well as, of course, the federal district court. So we are in regular communication with them about anything and everything happening in the jails, including all COVID-19 related issues, testing and otherwise. So that is sort of I would call it a double backstop, that you have both class counsel and the courts to ensure that we do what we're supposed to.
Okay, thank you. Let me just, hopefully these are just quick yes or no answers. I have raised several questions about testing of adults and youths in custody and staff, but I'm still not quite clear on the protocols for these groups. So let's see if we can just get this on the record. Are tests mandatory for custody staff? And if so, how is it being monitored and enforced? Is the first of 3.
Supervisor Ellenberg, this is Key.
Key.
Tests are not mandatory for basically county staff working in the custody settings, whether they be with the Custody Bureau or the Custody Health Services Department or Probation Department.
So it is not mandatory. Wow. Okay. Are we offering? I've been told that adults.
May I?
Oh, please.
Sorry. Yeah, this is Douglas Press. May I add? My understanding is that while there has not been a directive yet to require testing of staff, from what I've heard, that the reason is that there's been no directive is that it has not been deemed necessary yet because all staff have complied with essentially a request, if you will, to test. So it hasn't been a problem yet.
And we know that because we are monitoring.
We are
that part I don't know.
If I could just add to Doug's comments.
Sure.
Correct. We are hoping to achieve 100% compliance through sort of voluntary compliance. And as we indicated in the off-agenda report, we are going to sort of make testing available, encourage it, make it convenient, be able to try to be able to track tests that are provided through sort of other providers, aka non-custody health staff.
Right.
And then we'll see how far we get with the sort of voluntary compliance, and we'll report.
So that's the question. How many? I understand that it's voluntary. That's been clarified. How are we monitoring who actually takes advantage of it so that we can determine if in fact there is full voluntary compliance?
Right. So for each of the departments like probation or custody bureau, each of the department heads or departments are responsible for tracking and reporting that. And I'll be sort of collecting that information for the next report for the board.
Oh, okay. And that will be included in the next board report, just to confirm?
Yes, what we said in the off agenda was that we would come back with an off agenda on October.
I'm sorry, you broke up at the end. An off agenda on what?
By October 15th.
Sounds good. Thank you. And this is probably for you too, Key, the second of 3 final questions. I've been told that adults in custody who are being released to congregate settings may request a COVID test. Why, do you know why we're not just routinely offering this to all inmates? Obviously, we can't require there, but I think we should be proactively offering it rather than waiting for people to remember to or think of asking for one.
Just a clarification on that one. We've been offering that testing at the request of the congregate settings. And this was a request of some of those settings like residential recovery homes, etc. This came about in the early days of the pandemic, where there were concerns about, people coming from the jail and sort of who are COVID positive or close contacts, and then sort of exposing other people in those congregate settings. Since then, of course, we've implemented a lot of risk reduction measures, and that probably won't be an issue. But because we want to get people into congregate settings if they need to,
Sure.
we make this available.
Okay, thank you. That's helpful. I wasn't clear on who was initiating it. My last question is that it's my understanding that adults in custody will be tested on a rolling basis once every 4 weeks, but that there's no plan for ongoing testing for youth in custody. Is this accurate? And if it is, could someone tell me what the basis is for the different protocols?
Yes, it's not so much that isn't a plan to do that. It is that in consultation with the public health officers and probation, we feel that the youth are at less risk for infection, and then and since they're already being tested and quarantined when they get booked, that the surveillance testing isn't required. However, the health officer or health officers meet twice a week with probation and custody bureau, etc., to review the policies and procedures. And if they think that surveillance testing is a necessary risk reduction measure, then they will, advise the probation department and custody health, and those will then be implemented.
Well, we know that adults are also tested and quarantined when they come in, and yet we still get cases. Most likely, I think we've come to understand from staff coming in that may be infected and then infecting an inmate. Isn't that risk the same for kids, or is the difference because we think that if the kids are exposed, they're less likely to get sick or as sick or contract the virus?
Yeah, that's a good question, Supervisor. I think it really has to do with density. The density in the jail and Elmwood is higher than Juvenile Hall and James Ranch. If you would like some more specificity, Dr. Eureka Day is on and she can answer that, or we could come back with more specifics in the next off agenda.
Let's include that in the off agenda. I know that this is Dr. Day's very first meeting, so and I haven't even had a chance to have a conversation with her yet, so I don't want to put that direct ask on the spot right now. I would like it to come back with the off agenda. There may be, I may be answering my own question to some degree of because there's less density in Juvenile Hall, but there's still are, certainly staff coming in poses the same risks to kids as they do to adults. But I'm happy to have that included on the off agenda. And that concludes my questions for this. Thanks so much for the time, Supervisor Smidian. Joe, you're on mute.
Thank you. I was trying to make sure I didn't interrupt you earlier, and apparently did too good a job of it. I wanted to say thank you. Glad we were able to make the time. I actually do want to follow up on a couple of the threads that you pursued, Supervisor Ellenberg, and I'm going to go back to Mr. Press from our County Counsel's office. And Mr. Press, if you tell us you'd rather not answer in an open and public session because it's a confidential closed session matter appropriately, then I'll accept that. But I don't think we ever quite wrestled to the ground the question that Supervisor Ellenberg was pursuing, which I think is an important one, which is if either the sheriff or one of her staff says, I don't care what the public health order is, and I don't care what the direction is, I'm not going to require this particular behavior, let's just say mask wearing, what recourse, if any, do we have? And I'm thinking specifically of Section 25303 of the Government Code, which is where this tension is somewhat enshrined in state law.
Yeah, so the way I would try to problem solve it, well, quite frankly, probably would be something I would prefer to relay in closed session, because it is a strategic call, and probably not something I should preview in a public meeting in case others might have a different sense of strategy. But I would say what I would like to share would be something that would pretty closely track my previous comments about the so-called double backstop.
Yeah, I understand the double backstop, but at some point, to Supervisor Ellenberg's line of questioning, there is a important question and answer, which is who gets to make the call? Mm-hmm. And because here's something I can ask you that I know you can answer in open and public session, which is if one of the inmates or their family successfully sues us because our COVID protocol hasn't been sufficiently rigorous and there are adverse consequences, who ends up paying the $2 million, $5 million, $10 million judgment? I believe it's the county of Santa. Yes, and that money would probably come out of the general fund absent another source, yes?
Well, honestly, for a sum that size, we probably would have insurance coverage for a good chunk of it.
Let me try the question this way. Does it come out of the sheriff's budget?
To the best of my knowledge, it would not, but I defer to those who have greater expertise on budgetary withdrawals, if you will.
Yeah, I just, the trying to make it is that I understand and respect very much the independent authority of independently elected officials. I reference it frequently in these conversations, but the adverse consequences of decision-making are borne not by, you know, a particular independently elected official's office or department, but by the county, which is to say the taxpayers generally, whether it's from the general fund or through insurance coverage, which then results in increased insurance premiums in the future. And I know you know this, Mr. Press, so forgive me, but you know, every time we look at this issue, folks are quick to remind us that there are some limitations in Section 25303 of the Government Code, but I think it's important to remember that there also are provisions in the same Government Code section, including, quote, nothing contained herein shall be construed to limit the budgetary authority of the Board of Supervisors over the district attorney or sheriff, end quote, and quote, the Board of Supervisors shall supervise the official conduct of all county officers and officers of all districts and other subdivisions of the county, and particularly insofar as the functions and duties of such county officers and officers of all districts and subdivisions of the county relate to the assessing, collecting, safekeeping, management, or disbursement of public funds. It shall see, it being the Board of Supervisors, shall see that they faithfully perform their duties, direct prosecutions for delinquencies, and when necessary, require them to renew their official bond, make reports, and present their books and accounts for inspection. So there is not only some significant authority there, there is a reminder that notwithstanding the fact that we work with independently elected officials, that we have an obligation as well. So enough on that, but I'm gonna ask that we find a way to follow up on this issue, because to Supervisor Ellenberg's line of questioning again, you know, at some point we need to know how do we make sure this is happening and that it's real. And I, again, Mr. Press, I know you know this, but I just want to underscore the point. At some point, folks in jail go off to back to the community, and there are community-wide consequences. So not only do we have an obligation to our staff, the correction staff in the jail, and to the inmates, but it's not as if the larger community is unaffected by the decisions we make in this setting. Supervisor Ellenberg, am I following the thread, more or less the direction you hope we will follow it in future?
That's fine, yes.
Thank you. All right, then we'll let Mr. Press take a breath. And let me just ask this question, which I have been asking of late, which is we continue to hear more and more about antigen tests. And I've asked a couple times previously, and I just want to keep asking because I'm wondering if and when the accessibility of antigen tests, which are appreciably less expensive and provide quick results, albeit with less precision, less accuracy, when that might change our approach to testing. Is there anyone on the call from public health or elsewhere who can respond to that question?
I can start and just offer a couple of observations. I can tell you that we are, one, excited that antigen testing might come about because it could be less expensive, easier to deploy in the field, rapid results and all of that. The caveats, there are many. One is less sensitive tests, so you could have more false negatives. And the other is we have to think extraordinarily carefully about our surveillance. And so right now we have the diagnostic testing, those PCR tests that both gives you patient level information to know whether someone is infected or not. And it's also our surveillance data. It's how we report out trends because those tests are reportable. If you have a point of care test that's done by a person and not sent to a lab, then you lose that link for reporting and you lose it as a source of surveillance data. And so it's not just surveillance data here in the county, but we look at what's happening here in the context of what's happening in the state and the country, et cetera, et cetera. So this is really a very large conversation about how we use antigen tests and what data we also need for surveillance. So those are sort of some of the discussions that are ongoing as we look at antigen tests arriving on the scene.
That being said, Dr. Cody, the antigen tests as they are currently authorized do require a medical professional to be involved in an administration of the test. Yes? No? I should know that answer, and I don't know that answer. I'm not sure that's true. So I think that one of the obviously a test that could be administered sort of in the field, not linked to a medical professional and not linked to a, having to send it to a lab is exactly what makes them a little bit more nimble and adaptable to many of the testing situations that we have. So I will get back to you, or Dr. Fenstersheim will get back to you. Thank you for that. Let me share with you a recent question that, in fact, a question that came my way just this morning on a phone call with some business people in my area and Zoom meeting. And it's a question that I know you've gotten before and that we've talked about before, but I want to ask if you can frame a response today. And if not, if you can frame a response working with the rest of your team that goes a little farther than I think public health has been able to go before. As you know, because I know you've heard the question over and over again, people want to know what's the plan, what's the path, what's the roadmap, how do we get to a place where we can reopen this or reopen that, all understandable questions. And I think it has been frustrating for you in my observation because, as I've said 2 or 3 times before when we've talked, the honest answer may be, well, it depends and it's complicated. And that this is not like, well, if we get to 2% positivity, life is good and here's what will happen, that it's a little more complex than that. But is there a way you can articulate the sort of 2 or 3 things we need to see, which would then allow us to do the following 2 or 3 things? This, we got to wrestle this one to the ground, I think, because it just keeps coming up and leaving everybody, I think, sort of frustrated and disappointed. I'm not expecting you to have a spur of the answer spur of the moment answer today, but thoughts about whether with a little bit of time, like a couple of weeks, we could say, you know what, let me give you sort of conceptually something that looks like if this happens, then that can happen.
Yes, I certainly would love to have a concise answer that would be satisfying to all, and that might not exist, but we'll try to come as close to it as we can. The core principles that we do need to keep in mind are the same ones that we have been talking about for a long time, which is that we make a test of change. You know, and some activity starts to occur. We can guess, but really can't precisely predict what that's going to do to community-wide transmission. And so we need to wait a period of time, you know, at least 3 weeks to see what happens. So the latest example is we are now opening schools, you know, K through 12 schools. That's a pretty significant change. And so after that, we can predict what might happen. We don't really know until we wait and measure it.
Got it.
So
I do.
So that is going to stay foundational to how we'll work, and that is built into the state's framework, where you know, once you get to a tier, for example, you have to stay in that tier for 3 weeks. For example, say you're in red, and then all of a sudden your metrics go to yellow. You can't just, you have to stay there for 3 weeks, and you can't go directly to yellow. Actually, you can only progress one tier. You could only go to orange, so that there aren't any huge changes, because with huge changes, you really have no idea what the impact on transmission might be.
Well, I don't want to micromanage or even micro request today, but I'm looking at Dr. Smith's screen as I look at yours as well. And I really do think that, and I want to be very clear, I think the county operation has pushed out an awful lot of information in ways very user-friendly. But what I think we still don't have is a one-pager that pulls together language, essentially, hi, these are the 3 things that need to get better before we're going to be able to open up substantially more. Here's how long they'd have to be in place. And if they got substantially better, and they were substantially better over this period of time, and we didn't see any increase in the number of fill in the blank, hospitalizations, fatalities, then case numbers, then we would be able to do more in the way of A, B, and C, and X, Y, and Z. I think we have that information. I think we just haven't sort of figured out how to separate the wheat from the chaff and give it to people in a way that makes them feel like they can understand where we're headed. So that's the thing that, and I know you have more than enough work in your hands, Dr. Cody. So that's why I'm pulling Dr. Smith in and asking that the team work on some kind of description like that. Okay.
We'll work on it.
Thank you. And you know, I think running it by the folks in the public health office who have been getting these questions from the public would be helpful. I think running it by, frankly, the 5 supervisors' offices who are getting these questions would be helpful. It's like, does this address, so that you're asking folks, does this address the questions that keep coming? Because I think I think the lesson we've learned is that in order to have a successful enterprise, we have to maintain public confidence. And I think we would be better equipped to maintain public confidence if the public thought there really was a clear understanding of what's it going to take in order to get to a better place. Totally different question, Dr. Cody. And again, if you want to get back to us, I think you and I scheduled to be in the same venue a couple times later this week. So I have folks asking, if the 49ers can play football, why can't Stanford play football in its stadium? Is there a quick and easy answer to that, or is that a longer answer that you'd like to give some thought to? And or is there a path by which they might be able to play?
I think there's a longer answer.
All right. Well, I'm sort of quite purposefully putting that one out here in a public setting because I think we've got a lot of sports programs that are asking a similar question. And I know it's very activity specific and venue specific and protocol specific, but I do think as you had to juggle all these judgment calls, I think the why can't we, if they get to questions, are some of the toughest and thorniest. So I think we need to have some good answers there. I'm going to let it go at that and turn back to my colleague, Supervisor Ellenberg. Last call. Any other comments or questions on this item?
None. If there are no public speakers, I'm happy to make a motion to accept the report.
Well, why don't we go ahead with the motion? I will second the motion, which is to accept the report, convey our thanks to Dr. Cody and her team. But I would like to check with the clerk and see if we have speakers on this item.
We have no speakers, Mr. Chair.
All right, then I think we must have worn everybody out with yesterday's board meeting. So thank you for that from the clerk's office. Then we'll ask the clerk to call the roll, which is simply to accept the report.
Vice Chairperson Ellenberg?
Yes.
Chairperson Simidian?
Yes.
Thank you.
Thank you very much. Motion passes unanimously. That takes us, and thank you again to the staff. Takes us to the hospital integration report, item number 7. Presenting on this is.
Good afternoon, Chair Simidian. This is Paul Lorenz, CEO for Valley Medical Center, and Supervisor Ellenberg. The written report gives a pretty comprehensive review of our status. We continue to make good progress on the integration. Also included in the report is a supplemental from ESA on the unclassified position status. I know John Mills is on the line and could respond to any specific questions on that. So I'd be happy to answer any questions.
Thank you. I think those were questions that were of particular, I mean, they're interesting and important questions, but I think Supervisor Ellenberg had a particular interest. So why don't I defer to you, Supervisor, and see if you've got follow-up at this time.
Sure, thank you. And thank you, Paul, for this report. It's clear that there's a great deal of very important and collaborative work underway across VMC. I also appreciated the update from ESA on the unclassified employees, and I'm glad to see that more have initiated the recruitment process since last month. So yay, John, thank you. I am concerned, however, about the 6 employees who did not pass the recent round of exams, but as we know, have been working and presumably successfully at their jobs for multiple years. What supports are being provided to this group to help them navigate through the process?
Thank you, Supervisor Ellenberg, for that question. Yes, we are particularly focusing on these 6 individuals as well. The merit system provisions in County Ordinance Code provide for 3 additional opportunities for these individuals to retake the qualifying examinations for their classifications during the unclassified term. And the merit system rules also provide the opportunity for the individuals to review their scored exam and to get feedback on the areas of the exam where they might not have performed particularly well. And I think what we will be looking to do is working with the department in those specific areas to see if there are any additional supports that we can come up with between the department and the hiring manager in terms of additional training or supports that those employees might need.
John, how about a different form of test? We may have language issues, literacy issues that are unrelated to their job performance, but may in fact impede their ability to pass the same sort of test a 3rd time. Do we not have flexibility to make tests that are actually relevant to the jobs and appropriate in different ways from this standard literacy required exam?
Actually, Supervisor, particularly in the case of the janitors, and that is the real highlight and headline of this supplemental report is that of the 18 janitors who took the exam, 15 of them passed. And I think part of that can be attributed to the fact that we did exactly what you just described, and that we worked very closely with the subject matter experts from the health system to revamp the janitor exam. We modified various sections to address some of the concerns that you raise. And we also removed questions in the exam that historically had not performed very well in terms of passing rate. And we did not replace those questions. So the actual exam that was administered was much shorter than the previous exam that had been administered. And so I think that strategy that you described was very key to our success in getting the 15 out of the 18 that passed on this administration.
If this was a classroom of 18 kids and I was a parent of one of the 3 and you said it worked for the other 15, that would not be reassuring to me. If my child learns differently, needs something else, but is successful in other tasks, if these 3 custodians are successful, competent custodians, and there's no complaint about the quality of their work, then I think it's incumbent on us to find another type of test rather than give the same thing again and expect dramatically different results. If these are folks that are not going to be successful on this type of test, but we want to retain them because they've clearly demonstrated competency at their jobs, I think we need to be a little more creative, and that means different kinds of learning and testing. Again, just as we do for students, you can give a student who doesn't learn in one particular way the same test with all the supports in the world 10 times, they're not going to pass it. You do it orally, you do it kinetically, you do something that's active or some other modality so that they can demonstrate their capabilities and competencies, especially with such a small number. Again, and this all relies, on an underlying presumption that they are competent at their jobs. If there's not, then we have a different. If they are not, then we have a different issue. But I assume since they are still working and came to us having done this job for a while, that they can do their jobs. Let's
Absolutely,
not lose them because
Supervisor.
they can't pass this sort of written test.
Absolutely, Supervisor. And I think that's why our next step will be to work more closely on these 3 particular individuals with the hiring manager and the department to see what particular issues may be presenting themselves that we aren't already aware of since we're not with them in the department.
Great. Would you please provide an off-agenda report when a new testing format has been designed that they are going to take and how they do on it?
Sure. Although I will mention again that we did just revamp the exam, but we can look at that again.
Right. Again, you revamped an exam with different questions, but still a written sit down, take a test exam, and that won't work for everybody. Revamping to me means a different style and different modality, not just different questions.
We're happy to provide a report.
Okay, thank you so much. That's all I have on this item, Supervisor Smithian.
Thank you, Supervisor Ellenberg. Ms. Lorenz, you're still with us, I see, yes?
Yes, I am, Supervisor.
Thanks. So I'm going to come at this a little bit differently than I typically do and just say, remind us how long it's been since we bought these hospitals?
In about 1.5 years.
And so big picture, if you step back and I said, how are we doing? What would you tell us?
I'm very pleased. I think where we are today, I don't know that I would have expected to be for another year. So I think we've actually advanced the system much more faster than I had expected, even with the situation with COVID-19.
And the phrase advance the system in this context means what, Mr. Lorenz? Help me at least understand. Are we talking about, integrating our billing systems or filling beds or What does advance mean in this context?
I think the first part of it would be that we've maintained access to healthcare within the communities that these hospitals have traditionally served. I think that was the first priority of the board, and I think we have successfully done that. I think the second
Mr.
part
Lorenz,
of it is,
excuse the interruption. Yes. I just because and I apologize because I know I'll throw you off track, but I do think it's important, and I'm glad you started with that as number one, which is that for all of the challenges, right down to the test taking issues that Supervisor Ellenberg was just walking through with Mr. Mills, I do think the fact that every one of these beds was saved from extinction, more or less, by virtue of our acquisition, should be observation number one. I think we've gotten, unfortunately, to the point where folks sometimes sort of just move right by that and take it for granted. But there was, in the absence of any other bidders, and my recollection is there were none, it's entirely possible these beds would have disappeared. Yes?
well said, yes. That's absolutely
All right,
correct.
thanks. So if I wasn't clear enough about that, that's a pat on the back and a thank you. So, go team, go. So next item.
It would be the fact that as much as we've struggled with some of the transition around the employee onboarding, where we are today, I think the morale and the fact that the employees feel stable in their jobs is a big deal. I mean, without our staff, we would not have the ability to deliver these services. So I think there's been a lot of work done by the medical staff as well, as the frontline staff, nurses, and other staff within the healthcare system. So I think we've come a long way just in a year and a half to really create one system of care. And there's a lot of credit that has to go out to the staff within the system at all levels of the organization. And that's something I'm very pleased about. And that, of course, is the fact that includes the ability of leadership to really take a very close look at how we're operating as a system and being efficient and being prudent with taxpayer funds. And that's in light of the fact that, we're going through some very difficult budget times. And I think people have come together and really focused on what is important for the community and for the system. So a lot of credit needs to go out to the staff within the system at all levels of the organization. And you mentioned it, I think from a revenue cycle standpoint, the fact that we implemented HealthLink early on has really catapulted the system to not only take advantage, improve our revenue cycle processes over what the two hospitals had experienced prior, but it's also allowed us to really have the data and the information to be able to manage the health care system and the clinical care that we provide. So that in itself, and from a financial perspective, has been huge. And we've settled into it. And we're now on to looking at service line improvement, service line excellence. So we're on to the next phase, if you will.
Got it. When we look at data that says SCVMC, Santa Clara Valley Medical Center, is that plural or singular these days, just so I know what I'm looking at? Meaning, does it include all three hospitals, or is it talking about what we used to call as VMC?
Well, typically what we refer to as the three hospital system, we refer to as an enterprise. And so in most instances, you will see Santa Clara Valley Medical Center plus O'Connor plus St. Louis as the enterprise. So it depends on what report and how it's labeled, but generally speaking, we do still report out distinctly by facility.
Got it. So if I'm concerned that VMC saw what I believe was a $15 million net loss in July with net revenue and building production and cash collection and operating expenses all on unfavorable, that's specific to that particular campus, yes?
Yes, sir.
And my understanding is that notwithstanding the progress that you've described, O'Connor and St. Louis both lost money that same month as well, yes?
That is correct. for year to
And
date.
is that, yeah, and is that a function of COVID and the fact that we still don't have folks back in the hospital who otherwise might beneficially be there? Or is it some other factor that you can identify? How would you help us understand that?
It would be threefold. The first is the volumes are not where they were pre-COVID. And as you know, our budget is predicated on reaching the pre-COVID levels. And, we're still gradually recovering from it. It's only been, 6 months into it and only 2 months into the new year. So that continues to be a challenge that we are keenly focused on. Like I said, we are continuing to make progress there. There are some areas in the health system that may not change, and I would point out that ED visits still remain at 75% to 80% of its pre-COVID volume. And that's not necessarily a bad thing, because unless, as we focus on making sure that people receive care in the right setting, if you will, and that's the big push right now, as you well know, around video visits and other means in terms of outpatient care. But the other thing that I would point out is that the financials, as you well know, sometimes do not include supplemental revenues that come in at different times of the year. So that's another factor in terms of what you're looking at. And the third factor is that the COVID-19 response, which are expenditures that are within the VMC operating budget that are considered to be COVID-related one-time expenditures that we continue to incur that are not part of our normal operations. So we continue to work with the county executive to track our COVID-related expenses. So that is also in those financials as well. So those would be the three buckets that I would offer up to you at this time.
Got it. There's lots here to walk through if time permitted, but we do have other important items on the agenda today, and we want to wrap up on a timely basis. Anything else you or members of the team would like to share with us that you particularly want to highlight or call to our attention?
Not on this item in terms of the integration report. But again, thank you.
All right. Dr. Smith, anything from you?
I guess a little bit more on your question about how we're doing. The thing that we all look at, like you say, is service to the community, and one of the most critical components of that is quality improvement. And one of the things that we found, we knew this was true to some extent, but found it to a greater extent than we thought, was that there was, because of Verity and the daughters having a major financial problem, there was a major reduction in staffing so that they were actually putting some of their lines of business at risk. We've been able to build those back up, and we have really good performance records at this point and quality records. And as Paul points out, we're working on creating centers of excellence with some of those efforts. One of them most notably being a new robot for surgery that's done deep in the pelvis, which makes it a whole lot less risky and a whole lot more easily tolerated by patients. This is the kind of surgery that's done at centers of excellence with women and men with deep pelvic cancers and other major pelvic problems that are very difficult to do without the robot. And we have an excellent team of well-trained physicians, nurses, and technologists who are setting up a center of excellence. So I think there's been some real bright spots in the transition, and we continue to see more and more improvement.
Thank you. Supervisor Ellenberg, anything else on your comments and questions list?
Not on this item, thank you.
Then if we could ask for a motion to receive the report. And I will second. We'll check with the clerk to see if there are any members of the public who wish to speak on this item.
There are none, sir.
All right, then we'll call the roll.
Vice Chairperson Ellenberg,
Yes.
Chairperson Semidion.
Semidion, yes. That
Thank you.
means the measure passes 2-0. Thank you very much. All right, that takes us to item number 8, which is the Harvey Rose recommendations. And I see Ms. Solov here. And this is important and challenging set of issues to sort of wrestle to the ground. Ms. Solov, as I counted, there are sort of 5 large substantive areas here. Do you have the same count?
Can you hear me?
Thank you. I can hear you now loud and clear, Ms. Solov. I was asking, I've got 1, 2, 3, 4, 5 recommendations where you have significant suggestions, recommendations, and where the staff has I would say a significant difference of opinion. Does that sound right to you?
Yes, in our memo, subsequent memo, we sort of combined 2 of those together related to the general fund portion of the cash advance and the use of VHP excess funds. It's a similar vein.
All right. Well, would you like to make an initial presentation? Is that the best way for us to wrap our arms around these recommendations, and then perhaps we'll hear from staff?
Absolutely. Supervisor, thank you. For the record, Cheryl Solov, Management Audit Manager for the Board of Supervisors. As part of our annual review of the budget, it was apparent to us that the administration and departments were going to be working on their own sort of line by line changes and proposals. And so given that, we wanted to sort of take a 50,000 foot view of and kind of put out some additional thoughts about beyond just this current year budget, because this is going to go on for a while, where there's going to be uncertainty in the county's revenues, uncertainty in the county's costs, and it's really hard to predict that. So the purpose of the sort of introductory section of our budget report this year was to just put some ideas out there that could be useful in the event that, particularly related to cash, if the county were to experience reductions in cash, similar to the kinds of predicament that the county was in a decade ago, we wanted to just set out some ideas for ways to mitigate problems along these lines. So those ideas or proposals were not necessarily connected to the current budget or even the current financial situation, but just more looking across the horizon at what is out there in terms of risks to the county. So as you know, there's a cash advance or a loan, whatever you want to call it, from the general fund to VMC, and that the general fund and 3 other funds, depending on the day and time of the actual lending as well. And then, so we wanted to sort of think about that, and then also potentially loop VHP in, because they have excess funds in the VHP fund, the Valley Health Plan Fund, as a way to sort of offset the general fund commitment there. So that's one concept. The second concept is to sort of establish some sort of control around the extent to which general fund monies are obligated to the hospital system, because at the moment there's really not really a, in other words, whatever the losses are simply become an expense of the general fund because there is no other place for the monies to come from. So, you know, we were concerned about the potential for those losses to become large, and for there to be no kind of backstop against, you know, which the general fund could rely on what are its funds versus what may it have to furnish to the hospital system. And similarly, you know, to just sort of put a moratorium on new hospital capital projects being funded by the general fund, at least until we knew something about what kind of property tax revenues would we get in December, what's going to happen at the federal and state level. And then additionally, you know, we want to just consider a potential long-term change in perhaps substituting some non-physician staff for physician positions, simply to reduce the cost of operations. You know, and all of these things would have to be kind of long-term, and, you know, they're ideas to potentially preserve operations, depending on what happens with the county's funds. There's a lot of risk out there, so we just wanted to put forth some ideas for consideration, so that, you know, if things become difficult 6 months from now, there's at least some way to preserve cash and the operations that depend on that cash. Thank you.
Thank you. Dr. Smith, would you like to be the air traffic controller who identifies who can respond to each of these as we take them up?
Yes, actually, I'll start out and be the person you can ask your questions of, and if I need help from others, I'll let them jump in. So if you would like, I can try to go through the 1 through 5 myself, or
yeah, let me call them out in my own order, if I may, please, just because I think there's a lot here to grapple with. Supervisor Ellenberg, you okay with that if I just say, Dr. Smith, what do you think about this recommendation? Dr. Smith, what do you think about that recommendation, as a way to get started? Thank you. Dr. Smith, I want to begin where Ms. Soloff ended, which is with the suggestion that we, and I may ask for some back and forth here to try and get a better sense of what my own thinking is. But the suggestion was that we could transition perhaps as many as 100 physician full-time equivalents to non-physician practitioners. What's your thinking here?
Well, try to put it in perspective. It's true that a decade ago, Valley Medical Center did not utilize so-called secondary providers or nurse practitioners and PAs as efficiently and as effectively as they could be. And we've been changing that over the last decade. But there's still work to be done. I don't think it will actually end up being 100 plus, but we could definitely utilize more nurse practitioners in a number of primary care areas and some of the specialty areas. It's not as easy as it might seem, because it involves a complex process with the medical staff and privileging, as well as hiring, and there's a shortage of nurse practitioners at this point. But we do have that as a goal, and we are proceeding in that direction. So as Cheryl says, this is I won't say long-term, but a medium-term goal that we're pushing toward, but it won't be an immediate issue.
Is this something where the natural attrition in terms of retiring or moving physicians gives us opportunities, or no?
Yes. Basically, nurse practitioners in the state of California are authorized to function as independent practitioners under certain protocols. And so what is typically done and we push towards is a situation where lower acuity, more routine kinds of treatments are done by nurse practitioners and PAs, and specialty services or higher intensity services are done by physicians. But of course, as you know, this is really an issue of individual practice, and every doctor and nurse practitioner has a certain set of skills that aren't necessarily always the same, and that's why we go through the privileging process. So you have to match the privileges granted and the skill set to the particular job required, which does require, as you say, attrition.
Do we have a formal written plan with benchmarks to do this over the course of the next 2, 5, and 10 years, or is it just sort of a thing that is, quote, understood?
We have a head of advanced practice who is a nurse practitioner who I meet with on a regular basis. She has a plan of how she thinks things should proceed, has been working with the medical staff and the administration. But I wouldn't say we have a detailed Gantt chart about how it will proceed, because as you say, it will depend a lot on the attrition and the skill set needed and the volume of services needed. So it's more of a general plan than specific issue.
Is there a way to measure whether we made progress on this, a ratio, for example, between physicians and nurse practitioners, or some raw number, or if Susan Ellenberg came back to you 4 years from now and said, I want to know how we did over the last 4 years, how would you describe that to her, or to me for that matter? But she was handy. So thank you, Ms. Ellenberg.
Well, the only ratio that I'm aware of has to do with specific specialties. And so in primary care, there's been a lot of experience with nurse practitioners and PAs, and there are sort of average ratios that different health systems have. Some health systems use lots of nurse practitioners, like Kaiser, some use very few. And so that's an area where there could be some comparison in the market. Other utilization of different providers has to do with specialty care. So in some health systems, there's lots of nurse practitioners used in orthopedics, neurosurgery, GI, other specialties, but there's not really a sort of standard or common accepted model. Much of it has to do with the particular priorities of the health system and the physicians involved.
Let me turn to Ms. Solov, and I know we ask our auditing team to be experts in everything. Measurement or a tool that we could use that would tell us whether we had made progress from year to year to year?
Supervisor, I think the one way to do it would be to benchmark, to capture what the ratios are today, and then compare that to future ratios, across some, either overall or perhaps by specialty or, some other slice. If there might be slices that make more sense than other slices, and we would want to confer with the administration on their thoughts on that.
All right. Well, what I'm hoping to do today, Ms. Ellenberg and others, is sort of take a pass at what might be possible, then ask Ms. Solif to work with my office in my role as chair of the committee to tee up this conversation for possible action on any or all of these five, or not, but on any or all of these five at a future meeting. Ms. Solif, I'll probably end up asking you to work with my staff to sort of come back with some options for us about how we might actually address some of these things if it were the will of the committee and then the board. Before I go on to the $300 million cash advance, which is the next item I want to address, and I know Supervisor Ellenberg, you've had questions about that as well. Any questions or comments, Ms. Ellenberg, about physicians and nurse practitioners and how many of one and how many of the other?
No, not specifically on that.
All right, then, Ms. Solif, why don't you let us go to Dr. Smith and say, what's your take on this issue of the recommended action, which would reduce the general fund portion of the $300 million cash advance to VMC? Dr. Smith, thoughts? And then I'm going to go to Ms. Ellenberg, just because, as I say, I know she's had comments and questions about this in the past, but I'll start with Dr. Smith.
Well, we had a very thorough discussion of this during budget, and the distinction between cash and budget seems to be the core issue here. Cash and cash flow has to do with actually meeting responsibilities in a timely way, whether it's payroll responsibilities or contract responsibilities. And we have, ever since the hospital existed, had the responsibility of meeting payroll and had the issue of reimbursement, patient care reimbursement being periodic. So always we have utilized, to one extent or another, cash from other funds in order to make payroll. And it's not really a loan, it's really a cash advance, and it only exists because of the structure of the enterprise fund. For other health systems that are where the hospital is part of the general fund, it's never even seen because it's stated explicitly that we have that responsibility. So, for example, other departments like the DA's office, we don't call it a cash advance, we just pay payroll. That confuses oftentimes the issue of the general fund subsidy, which is a budgetary issue, not a cash issue. General fund subsidy is a planning during the budget time period to balance the enterprise fund. We know that we take care of lots of people who are uninsured or underinsured, and so therefore it's impossible for the enterprise fund to actually function with a profit or without a loss. And so that loss has to be covered, and it's covered by the general fund. And in this particular county, we have a different definition of general fund subsidy than other counties do, which I can go into if the committee wants me to, but we've been actively working for the last 10 years to reduce the general fund subsidy by increasing the efficiency of the hospital and health system, increasing our attention to the revenue cycle, that is, to make sure we do all of our collections as rapidly as possible, and improving our one-time funds through various state and federal programs that give us lump sums that aren't directly related to specific patient care. So we were able, over the last 10 years to reduce the initial subsidy when I started here of about $240 million a year down to about 80 million, but we've seen an increase now having to do with a number of issues, one being the economy, another being the threats on ACA, the Obamacare, so to speak, another being the purchase of the hospitals, another being a decrease in patient care needs secondary to COVID. So the general fund subsidy will fluctuate off and on for the next 3 or 4 years as we try to get it back under control.
Would you repeat the subsidy was this amount and then we got it down to that amount, just so I can scribble the numbers down again, even though I've seen them in other places?
Yeah, I don't have them right in front of me, but when I started, it was about $240 million of general fund subsidy. The lowest we got it was down into the $80 million range.
Okay.
It's now back up.
All right, Dr. Smith, what I'm going to do is I'm going to stop and go to some of these issues, and my colleague, Ms. Ellenberg, has indicated that actually she'd find it more manageable if I would just get my questions squared away and then go to her for her questions cutting across some of these different issues. So let me just ask, Ms. Sullivan, on the $300 million a year cash advance, and Dr. Smith, I'm going to offer an odd and somewhat simplistic analogy. It seems to me that it's I got $1,000 rent due every month on the first of the month, but at the end of the month prior, I always have $700, which means I need $300 to make the rent. I know I'm going to get enough money to cover that when I get paid for my job in the 15th of the month. But meanwhile, I got to pay the rent, so I need to borrow $300 from my brother-in-law. Dr. Smith, is that what's going on?
I'd add a little bit more nuance by saying, let's presume you're a tradesperson and you have jobs from time to time. So you're a carpenter. You know that you're going to have more jobs lined up, but you don't have the revenue from them yet. So yes, you borrow $300 from your brother-in-law because you know that you have 3 jobs set up next month.
But once I've borrowed the $300, it's a one-time only event. It's not like I need $300 a month, which is why it's a cash advance. Yes?
Well, oftentimes,
except at the end of the budget year, we have to say we're going to do the cash advance again for the coming year.
Right. And in the way it's set up now, it's set up as a cash advance that we don't utilize unless we need it. And if we do utilize it, we pay back more money to the general fund than is utilized. And, obviously 300 million is a round number, so that's an estimate of how much we might need, but probably we won't need that much.
Ms. Sullivan, this is my gross oversimplification and tortured analogy here, at least an accurate one. Let's start there. Or have I misrepresented or misunderstood how the cash advance works? Because that's my understanding is that's the distinction Dr. Smith is trying to focus on between budget and cash.
Yeah, I think your analogy is appropriate.
Okay, so it's not that it's a quote ongoing cost as much as it is that more or less in perpetuity that's a dollar amount that we'll, quote, never have access to for any other purpose. Yes, Ms. Soloff?
I don't know about in perpetuity, but for the foreseeable future, the brother-in-law has to keep $300 available for his carpenter brother-in-law.
Right.
Yes.
All right. Well, we really are stretching here. Okay, that'll teach me. Thank you. So your suggestion, as I understood it, Ms. Soloff, was that we find somebody else to, rather than the general fund, to provide some piece of that cash advance as a way to free up some other funds in our general fund, for our general fund, so that we could spend it on other things. Did I get that part right?
Well, or maybe not necessarily spend it, but at least have the flexibility to spend it on something else in the event that, say, you don't get your property taxes in as you anticipate.
Right. So was was VHP one of those somebodies?
Yes.
So Ms. Soloff, are we talking about, for example, saying, why don't we let VHP from its cash reserves toss 10 million towards the problem, and then that frees up $10 million in our general fund? Ms. Soloff, am I following the money here correctly?
I think our proposal was 15 million, but yeah.
Okay, so let's call it 15. So Dr. Smith, what's your thought about that?
Well, the enterprise fund of VHP has got its own responsibilities and its own cash operations, and we don't put any general fund into VHP. So utilizing money from cash from VHP causes problems because it's not general purpose funding. It causes problems with our compliance with state health plan laws. It's not a appropriate utilization of the T&E. And if you want me to go into detail about that, I can, but it'll bore the heck out of everybody.
Is it a legal issue?
Yes, the health plans are required to keep a specific amount, a minimum specific amount of T&E, which is essentially their reserves, their cash reserves, and those cash reserves are kept because a health plan might get a large, very large claim. You know, somebody shows up in the ER and stays in the ER and then ends up in the ICU for 3 months. That's a huge claim that has to be paid. And so they have to have a cash advance. So if we utilize cash from the health plan T&E, we're limiting the cash utilization of the health plan, and we get in trouble with the auditors from the state because that money's supposed to be used for claims, not for cash flow.
Okay. But it sounds to me like if we got really desperate, somebody could say, gee, if we need to free up some general fund money, we ought to ask ourselves whether we could take $5, $10, or $15 million as a loan from VHP to the 300 million cash advance and still leave VHP with what is lawfully required to have in the way of reserves. Can I get an unenthusiastic yes from you on that, or is that still stretching too far?
That's still confusing budget with cash. You know,
yeah, but it would be a one-time opportunity, yes?
But why would you want to do that?
If you needed some one-time only money in the general fund to get through a true crisis.
Well, let me give an example. When we had the cash flow problem a decade ago, we did take cash from Park Charter Fund and some other funds in order to deal with that cash flow problem. In this situation right now, we're not in that position where we need to take money from those funds. So if I was going to make a prudent and responsible recommendation to the board to raid another fund, it would not be the Valley Health Plan. It would be something like the Park Charter Fund or the Roads Fund, which
Okay.
have different rules.
All right. Because we've mushed together, forgive me, 2 or 3 of these related financial items, part of the recommendation from the Roads organization was to consider establish a maximum general fund obligation to the VMC operating losses as a percentage of general fund reserves. Thoughts about that?
Only do that if you're willing to fire a bunch of nurses and doctors.
I'm sorry, Dr. Smith, it may just be an internet problem, but if you could try that again, I would appreciate it.
Thank you.
You can only do that if you're willing to downsize the hospitals on a regular basis, because the
go ahead.
funding, it's again a budgetary issue, and the funding limits the amount of ongoing expenditures we can have. So for example, if the board said that we could only use a certain amount of money for the general fund subsidy, every year there would be a requirement to reduce staff at the hospital because we never make money off of the hospital.
I'm going to say I'm not persuaded that that's the necessary consequence. I'll let Supervisor Ellenberg follow that up if she wants to. I think, you've, in fact,
Let me try to explain it again. The employees at the hospital and health system are represented by unions who negotiate MOUs with constant raises in their reimbursement. We know that starting out just from basic year 0, our costs are higher than our revenues collected. If you limit the general fund subsidy, every year you have to reduce the number of employees by the amount of money equal to what the general raise was in order to keep that number, solid.
Excuse me, Dr. Smith, excuse me, unless you find other ways to achieve savings, which is presumably what you did to get the general fund subsidy down from 240 million to 80 million. And if, for example, and I'm looking at Mr. Lorenz's square, if, for example, you increased the number of patients who had commercial insurance, if you increase the number of billings that were sent out, which I know at one point, Dr. Smith, you were very focused on and I think successful with, if you increased the efficiency of our collections, which I believe is another area that you were focused on and successful with, those are other ways besides simply, quote, reducing the size of the organization to limit the subsidy. And the reason I'm pressing on this point is otherwise you are essentially saying, in any given year, however much the hospital loses, we just have to accept that and we have to pay that out of the general fund, which is not a very good budgeting mechanism in my assessment.
Well,
back to you, sir.
Let me push back and try to, again, distinguish between budget and cash. You're right that we do push efficiency and effectiveness and rev cycle, and we've been extremely efficient and effective in doing that. However, you can't book that during the budget. Those are ongoing processes. You can't say responsibly that you're going to guarantee that you're going to increase the efficiency by 10% or 12% or 20%. And when it comes to July budget, you have to project what your current costs are and what your current anticipated revenues are, and they have to match. So, you know, it's not the kind, if you fix the contribution from the general fund and say it'll never go above that, you're sticking yourself with definitely having to reduce staff in the hospital.
Dr. Smith, I'm just going to let this one go because I continue to disagree, because if I had made efficiencies in one fiscal year, which I then had established, I could book them in the coming fiscal year, even if I hadn't taken them in the budget in the previous fiscal year. Let me just go to the last item, which is to say the recommendation from the Rose Organization was to prohibit the use of general fund revenues towards new hospital capital projects, including acquisitions. I'll ask you, Dr. Smith, what your thoughts are there and what either possibilities or challenges that recommendation suggests.
When we do capital projects at the hospital, we spend the money out of one-time general fund, and then we get reimbursed with a lease revenue bond from the hospital's operating budget. So the money is not a contribution from the general fund. It's functioning as a landlord. If you actually tried to do all of the capital improvements only with funds from the enterprise fund, you would not be able to do any projects at the hospital because the enterprise fund every year is in a deficit position. So the, you know, adolescent and adult children or a psychiatric facility would not happen.
Okay. Ms. Soloff, do you have a reaction to that?
Yes, sir. As far as like the adolescent and adult psychiatric facility, we specifically, that and anything else that's actually underway is not part of our recommendation. We were just trying to minimize new proposed projects in the short term here.
Okay.
Because as Dr. Smith correctly pointed out, there, you know, ultimately all the money for this is coming from the general fund. So, and then I just wanted to push back on a couple of things. Our recommendation regarding, or proposal, I guess, regarding, you know, setting some sort of a cap on the hospital's share of the general fund, it was proposed as a percentage of revenue, not as a dollar amount that would be fixed in perpetuity. So I just wanted to clarify that. And then the third thing I wanted to clarify is our recommendation regarding the VHP funds was specific only to the excess funds over and above the legally required reserves.
Thank you for both those clarifications. Thank you, everybody, for your patience with me walking through those. I want to turn to my colleague, Supervisor Ellenberg, for her observations and questions.
Thank you so much, Supervisor. You really did handle the bulk of the issues on this item, so thank you for that. I have just 4 questions that I'd still like to ask. And Cheryl, I'll start by kind of following up with where you just left off on the subsidy and your recommendation. You propose to install a control mechanism on the size of the general fund subsidy. It seems reasonable to balance the general fund investments in the hospital system relative to other parts of the county organization. I very much support that. What do you envision in a scenario like the one we're currently in with the pandemic, where forces beyond the board and hospital administration's control might take us just far off the course of that administrative cap. Might we say that the board approval of the annual budget with a budgeted amount for VMC subsidy functions as a similar expression of the cap to administration that they should aim to stay within?
Thank you, Supervisor, for your question. I didn't hear the very last part of it, but I think I got the gist of it, and I'll do my best. So
Sure.
I think what you're asking is, what happens if there's some crazy scenario, and if we cap this, and then there's,
And also,
the
do
bubonic.
we essentially have a cap function because we approve the board approves the budget?
Oh, I see what you mean. Because of the subsidy, I think the subsidy is one piece of it, but because there's additional flow of funds that are not part of the subsidy, so that's another piece of it. And then just some sort of metric because the subsidy right now is not contingent on what the general fund has. It's just the subsidy tethered to the need of the hospital, as opposed to being, reflective of the ability of the general fund to furnish those monies.
Yeah, I appreciate that. And it seems that multiple things today in this meeting are just continuing to lead me to draw parallels to education and thinking about the budget for special education. It's not tethered to the school district's general fund or what other funds they have for other programs. It's just whatever the need is. It has to come out of the general fund without a cap. And as a school board member, that was very challenging at times, and it's challenging here for almost exactly the same reason, that it really is, unless we make a policy decision from a pure financial position, I hate to say this expression because it's been co-opted, but it is what it is. If the expenses have been incurred, then we need to pay them unless we really make a shift in our policy and say that we don't do more than that. I think that this is a really interesting question, and it's much bigger than just an accounting decision. It's really a question of where the hospitals sit within the context of our whole budget, and where, as a board, we prioritize the maintenance and strength of the hospitals, potentially to the detriment of other county programs, employees, services, et cetera. So I think that you've given us in your audit, regardless of where you and administration agree and disagree, really a lot to think about, and I think a lot for I and my colleagues to talk about that. I'm going to switch to focus the next couple of questions to Jeff and Paul. Many of the recommendations focus on directing administration and VMC to control costs as much as possible, of course, including staffing costs. And again, whether or not there's agreement with the administrative controls that are recommended by Harvey Rose, what specific steps are being taken as part of the budget process to bring down the size of the subsidy going forward and to reduce the impact on general fund? What is your strategy?
I'll start, and then Paul can jump in if he wants.
Thanks.
The main focus of the system in terms of getting the costs down is to maximize the reimbursement that we have for the services that we actually provide.
As opposed to, or to the exclusion of increases in our own operational efficiencies?
Well, I'm getting there.
I'm sorry, I apologize. I shall mute myself and listen politely.
So historically, VMC and lots of other public hospitals were very bad at revenue cycle. That means capturing the charges for the services they actually provided, reporting them, billing for them, and getting reimbursement for them. In a disproportionate share hospital like VMC, that has a double whammy effect. Not only do you decrease your reimbursement for particular services, but also then you don't have the ability to bill for special reimbursement through Medi-Cal, which is done as a lump sum funding mechanism. So increasing rev cycle efficiency and effectiveness is a big deal. Again, also, like you said, the efficiency of operations is also a huge deal. And that's a much more challenging effort, which we have had ongoing for the last 12 years. And we will continue forever, because it really means re-educating and re-educating again the culture of the operation, so that we get the right service to the right patient at the right time with the right limitation of expense. And you know, that's a big focus of efficiency. And I would say that that was one of the major positive efforts that created a decrease in the general fund subsidy. And then the last is trying to make sure that we get the, excuse me, I'm being distracted here. So efficiency, effectiveness, rev cycle improvement, and making sure that we lobby effectively for reimbursement programs at the state and the federal level that will advantage us in not necessarily to the disadvantage of anybody else, but make sure that we get appropriate reimbursement. So we're constantly at the state and the federal level trying to change the formula for QIP, the formula for Prime, making sure that we keep track of the 1115 waiver. We have with us consultants today who will give a report on what's going on at the federal level. But the constant threat from the state and federal governments is to reduce the reimbursement for the services to patients that we are responsible for. So,
right. I do understand that, and I know that there's much that we can't control, or where our influence is limited to advocacy. I would like to see, anytime we are talking about the hospital financials, particularly as it impacts the general fund. So each time in each budget cycle this year, quarterly, to really see a much greater breakdown, not only of how the general fund dollars are used, where that subsidy is used, but each time to include specific recommendations on where greater operational efficiencies or other changes can be implemented that will bring it down. Things that are within our control, as opposed to the reimbursements and the waivers and the things that unfortunately we just cannot count on. But I think, and this may be something that has to come through a referral so that it's formal board direction from all of us. But I think that a goal clearly needs to be a reduction of the hospital system's reliance on general fund dollars.
Yeah, we can do that. You don't need to do a referral. We'll be happy to do that.
Terrific.
I would also want to explain a couple of things that I think the board knows about, obviously, but public might not know about.
Mm-hmm.
I mentioned earlier that the general fund subsidy is calculated different here than it is in other counties. I wanted to elaborate a little bit on that. Santa
Very
Clara-
little for purposes of this meeting, since we still have quite a bit of agenda left.
Okay. There is a general fund subsidy or grant, which is part of the subsidy, which is just straight out money from the general fund that's budgeted to the enterprise fund. That's actually a significantly smaller amount than the subsidy. The subsidy also includes costs for inmate and juvenile health care, because we're not reimbursed from anybody else. So the general fund is responsible for that no matter what we do. And it also includes contributions from realignment and tobacco tax. So those aren't typically included in other counties when they calculate their subsidy.
Interesting. And we should be very careful to break them out too, so that we really do understand exactly what dollars are coming from our own general fund and what dollars are coming in from any of those buckets that you just mentioned. I think that is a good point. Thank you. Let me ask I've got two more questions about capital projects. In general, when it comes to capital projects, I'm actually more concerned about change orders and added costs to projects that are already underway than I am about the initiation of new projects, because of course the board has discretion to approve or reject them. What I'd like to know is what controls are being utilized to control capital project costs and change orders, given the increased financial constraints the county is facing. And I know that, nearly every board meeting, the consent calendar has any number of change orders and increased costs that we're being asked to improve and over which we have virtually no control. How do we gain control?
Well, we do have a project management team assigned to every project who keeps track of the expenditures. I would say that in the last few years, the project or increased supplemental allowances has increased primarily due to the market and the fact that the cost of raw materials goes up, and also the effective bidding process that we're using invites supplemental allowances, because we're putting together projects in a very fast mode. So for example, you just talked about the psychiatric facility. We're doing a bid as a construction at risk, construction manager at risk model, which means that they will take part of the risk and the county will take part of the risk of future changes. And, the board has asked for change orders already. So we can anticipate there will be some supplemental allowances, and we try to negotiate them down to the very minimum. But, it is a challenging effort, that's for sure.
It is, and I think that we probably need to be a little bit more specific than just trying to keep them down, whether it's in the way that we contract, where the liability, it's not the liability, the responsibility is shifted, and from our own internal budgeting process. If we know that traditionally or historically projects tend to be 15 or 20% over budget, number one, a question of course is why. To the extent that there's some inevitability internally, I hope that we are budgeting for that fully predicted amount, so that we are not surprised internally, even as we continue to work to keep the costs down externally.
We'll have to give you an off agenda to explain it in more detail.
Okay, that's fine. I would appreciate that. Thank you. Just wrap up on this item. I really do appreciate the push to assure that our hospital system runs as efficiently as possible and reduces the draw on the general fund. And thank you again, Cheryl, for your tremendous work on this. This was a priority before the pandemic, as part of the hospital integration process and is even more critical now. But that said, I believe that the board already has the tools through the budgeting process and the approval of new capital projects to effectively carry out the intent of this package of recommendations to bring down the size of the subsidy. And I do expect that this will continue to be a focus in our November and February budget discussions. So thank you very much. And I am prepared to, I'll just move approval of this item.
Supervisor, could I just make one comment?
Of course.
Dr. Smith, we have a hard stop at 5, as you know, and it really does need to be just one sentence, please.
I think that Supervisor Ellenberg is exactly right. The board has all the discretion in the world during the budget process to limit or change or modify anything.
Thank you. You could
All
stop at Supervisor Ellenberg is exactly right.
All right. Duly noted. And Supervisor Ellenberg, do I have a motion then to carry this, receive the reports and return on this item as needed? Can we call that a motion?
We can, we do.
Thank you. I'll second and I will check with the clerk to see if we have any public comment on this item.
We do have one speaker, Mr. Chair.
Thank you. Go right ahead.
Okay. Our next speaker is Kaleo Gagne. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Good afternoon, Supervisor Ellenberg and Supervisor Simidian. My name is Kaleo Gagne, and I am speaking on behalf of my husband, Greg Feast. He is a registered nurse that works in the emergency room department at O'Connor Hospital. Every day he goes into work, and I'm concerned for his safety due to the COVID pandemic. He, like many of our nurses, selfishly go into the work to take care of our families who are in hospitals, always putting their lives at stake. I am asking the Board of Supervisors not to consider the delaying of the 4% increase based on the RMPA's county MOU that's due in October 2020. This, I feel, is a discourtesy to our frontline heroes. Please honor our nurses by not considering this, but allow them to get what they truly deserve. This is not the time to make our nurses' lives harder during this pandemic. Many of our families, they have lost jobs, they have lost businesses, and some people have a tendency of being already the breadwinner. So please do not consider this the delaying of the 4% increase, because this is really important for our nurses. Thank you very much, and thank you for all that you do.
Thank you for your comments. Let me just confirm that we have no additional speakers, or do we, Mr. Clerk?
We have no further speakers on this item, sir.
Thank you. Then we have a motion by Ellenberg and a second by Simidian. Please call the roll.
Vice Chairperson Ellenberg.
Yes.
And Chairperson Simidian.
Yes, motion carries unanimously. Thank you very much. That takes us to item number 9. This is to receive the report from the Emergency Medical Services Agency relating to proposed updates to the agreement with Rural Metro of California. Supervisor Ellenberg, we had initially had a request from staff to put this item on essentially as I'll call it an action item to forward this to the full board on relatively short notice. I was uncomfortable with that for a variety of reasons and asked that it be on our agenda as an information item today, tee it up, and then come back and actually have some meaningful discussion at our next meeting in October. For that reason, and given the lack of time, I'm going to defer any comments or questions. I appreciate administration pulling together the background so that we now sort of have, a real opportunity to think this through and then have a substantive discussion in October. As you referenced, we're tight on time, but if you have any quick comments or questions or requests for information you'd like to make sure we get before we get to the decision dates in October, please go ahead.
This item.
All right. Then can we ask the clerk?
There are no speakers on this item, sir.
All right. Well, I don't know. Apologize or say you're welcome to the folks from EMS who've been standing by. Moving right past this one, but we'll take a motion from Supervisor Ellenberg. Thank you to do the recommended action, which is simply to receive the report. I will second. We'll ask the clerk to call the roll.
Vice Chairperson Ellenberg,
Yes.
and Chairperson Simidian.
Yes, and my apologies for the struggle with time management today. That's on me as the presiding officer. So thank you for that. That then takes us to item number 10, which is the opportunity to receive the report from Working Partnerships USA relating to healthcare reform, implementation, and the public meetings. And I think, Mr. Brownstein, are you presenting on this? I see your visage on my screen.
I and my colleague Vaughn Villaverde will be making the presentation, and I understand time is very tight, so let me go straight into it.
Please.
We'd like to take this opportunity to highlight one of the research papers that we have been working on in the spring. The subject is the relationship between housing and healthcare. It's been long recognized that that relationship is a significant one, and the COVID pandemic only highlights the urgency of recognizing this. And I will now turn to my colleague, Mr. Villaverde, to go over some of the findings from our research report. Vaughn, if you could do it a little more quickly than you had planned.
Thank you for that.
And yep, I'm sorry about that. And let me just go ahead and share the screen. So we, as Bob said, I'm sorry, my name again is Vaughn Villaverde, and I'm the Associate Director of Health Policy at Working Partnerships. In our research, we really wanted to approach it using this framework where we took a look at 3 aspects of housing. The first being internal housing conditions, because it directly impacts folks' ability to shelter in place. We also took a look at neighborhood and area characteristics, because that has a direct impact on how people are able to cope with the shelter in place directive. And then the last thing that we took a look at was housing tenure and residents' ability to retain their housing, because housing, the length of time you stay in housing magnifies the positive and the negative health effects of the housing. So in terms of internal housing conditions, we really wanted to highlight 2 specific areas that have cropped up since COVID-19. The first being overcrowding. According to HUD, overcrowding is defined as having more than 1 person per room. And I want to make a note that we're talking about per room and not per bedroom. And severe overcrowding is defined as having more than 1.5 persons per room. Based on these definitions, we found that San Jose has the 2nd highest rate of housing overcrowding in the United States. 10% of San Jose's housing units are overcrowded, and 4% are severely overcrowded. 1 in 4 children live in overcrowded households. And interestingly, San Jose has more overcrowded housing units than San Francisco, despite having less than 1/3 of its population density. As folks can probably imagine, overcrowding in homes really undermines the goals of the county's efforts to slow the spread of COVID-19. It reduces the ability to distance from each other within the home. And also we found that people living in overcrowded households are more likely to be lower income and work in service jobs that have regular contact with the general public, further exacerbating the public health concern. And one of the key subpopulations that we wanted to definitely bring to your attention are older adults in skilled nursing facilities. As we have seen in the news, older adults in skilled nursing facilities have been disproportionately hit by COVID-19. And so it only underlines the urgency and the importance of transitioning SNF residents who are eligible for transition back into the community where there are fewer risk factors. The second issue that we found that has kind of been exacerbated by the COVID-19 pandemic is domestic violence. That's because, you know, with the shelter-in-place directive, there's been more prolonged contact with the abuser, fewer means to escape, and less access to community resources and social support. And the Santa Clara County Sheriff's Office has seen a 46% increase in domestic violence-related calls, while seeing a decrease in the number of survivors seeking help from local agencies. Um, the county's doing a lot of really great things regarding support regarding COVID. The COVID-19 support network is particularly helpful in providing resources and linkage services to critical support like food, clothing, transportation, and cash assistance. And Santa Clara County has also made significant investments in the Office of Gender-Based Violence Prevention. Moving very quickly to neighborhood and area conditions. When we submitted the report, we were really focusing on neighborhood amenities and resources. But since we submitted that report, a couple other regional environmental factors also popped up that have affected the community's ability to adhere to adapt to COVID-19. So amenities and resources in a community really dictate whether or not residents are able to cope both physically and mentally with the shelter-in-place directive. So it's really important that we keep parks open and we keep community centers open as centers of distribution for relief services and resources. But also we found that regional environmental factors have really exacerbated COVID-19, particularly a combination of COVID plus excessive heat plus poor air quality. The best practices on how to mitigate these risks sometimes have been in conflict with each other, particularly when it comes to, ventilating the house to prevent COVID, while at the same time the air quality outside is very poor. So there's also been challenges regarding emergency communications on blackouts and evacuations and things like that. And then regarding housing tenure, what we found was that positive and negative health impacts of housing are magnified over time. And we found that even the positive impacts can be undermined by housing-related financial strain. Probably the most relevant to our discussion regarding COVID is that we found large-scale studies that have shown that housing unaffordability often forces households to make trade-offs between housing costs and paying for healthcare services such as provider visits and medications, and that definitely undermines the county's effort to slow COVID. And it's also had a huge impact on housing, families or households' ability to remain in their homes. So 46% of renters in Santa Clara County were already struggling to pay rent, meaning that at least 30% of their income was going towards rent. And then add that to the shutdown of non-essential businesses, where a lot of households have experienced a sudden loss of income, and it's made for a really precarious situation in terms of families throughout the county trying to retain their households. And lower income households in the service sector, hospitality, and retail have been mostly impacted, and Black, Latinx, and immigrant and women-held households and families with young children are disproportionately at risk for losing their homes. I apologize for going so quickly. With that, I'd like to toss it over back to Bob, who will go over our recommendations.
Thank you. I'm going to break the recommendations down into three buckets. The first one is don't stop the county activities that are proving beneficial in this area. That includes the services provided for people who are living in overcrowded conditions, providing protection to tenants against eviction, and constructing affordable housing with Measure A bond proceeds. The second bucket, find resources to do more in several areas, and these include providing rental assistance to prevent homelessness, providing even greater support for domestic violence victims, and aggressively seeking sources of additional capital to build more affordable housing as quickly as possible. And the third category is new actions. And under that, I would like to emphasize two particularly. They both have to do with making existing laws work better for people who need the protection of those laws to assert or defend their rights. One is to educate tenants and landlords on the eviction protections included in recently passed AB 3088. AB 3088 enables people to convert unpaid rent into civil debt, but to get the protection from the statute, you have to meet certain active requirements. You have to take specific steps. If you don't understand what those are and you don't take the actions, you will not get the protection. Therefore, education could be extremely useful and helpful. Secondly, expand legal services for tenants going through eviction or civil debt proceedings. Perhaps one tenant in 20 has legal counsel in eviction court, and the results bear little resemblance to any notion of fairness or justice. Without counsel, tenants really cannot present the case and have any hope of being successful. And we have recently heard the Law Foundation of Silicon Valley is thinking about the idea of establishing in Superior Court a collaborative court model for evictions, somewhat like those for drug abuse or family court, and the county might be interested in also considering that kind of idea. So those are some of the recommendations we have, and we'd be happy in the remaining 180 seconds to answer any questions that you might have.
Thank you for the speed presentation, and both of you did an exceptionally good job under difficult circumstances. Ms. Ellenberg, I'll go to you to see if you have any quick comments or questions before we wrap up here in a moment or two.
Not at all that would do justice to the thoroughness and usefulness of that report. I really appreciate it. There were very few surprises in there, but a lot of very strong and very well backed up messaging. And I certainly believe this should be our guidepost going forward. Thank you very much.
Yeah, thank you. I would echo that. And I would also just say, I think sometimes even if there's not a lot that is, quote, surprising, organizing the thoughts in a coherent way so that they are sort of a crisper and clearer is a very helpful exercise. And that was the way I felt about things, even that had been understood perhaps, but as I say, not as well structured or organized. So thank you both. All right, can we get a motion in the absence of any public comment, and the clerk has not indicated, we have a motion to accept from Supervisor Ellenberg. I will second. Mr. Clerk, call the roll, please.
Vice Chairperson Ellenberg?
Yes.
And Chairperson Simidian?
I'll say aye and say that the motion carries unanimously. And thank you again, Mr. Villaverde and Mr. Brownstein. Appreciate it.
Thank you.
All right, that takes us to our last item, although it is far from a light one. And what I think I'm going to suggest, Ms. Ellenberg, is that we simply roll this item over for the most part into our next meeting. And my apologies, Mr. Santiago, I see you all teed up and ready to go, but I think it would be disrespectful to ask people to give 5, 10, or 15 seconds if, and we've got some presentations that I think it would be very helpful for our committee to hear more thoroughly. So again, my apologies for the challenges with meeting management. I will say that Mr. Margolin, if you can let us see you for one brief moment here, as we have now 60 seconds left.
Yes.
My question is, what's the single most important thing you want us to know about healthcare in the federal environment right now?
The federal government is not going to shut down because a CR was passed last night, but the Ginsburg vacancy has put the ACA at risk. There's a November 10th hearing scheduled on the Texas litigation, and that's an issue we all have to follow very closely.
And right now, that means that hearing will have just 8 justices?
Unless they're able to confirm and place a 9th before November 10th, which the president seems determined to try to do.
Got it. With that cautionary note, Supervisor Ellenberg, a motion to continue item 11 until our next meeting would be gratefully accepted. Thank you. Again, my apologies to others who have been waiting, although I know it's the practice to sit through the full meeting so that everybody's sharing information. I'll second. And in the absence of any public comment, Mr. Clerk?
There is no public comment, so I can call the roll if you'd like, sir.
Please.
Vice Chairperson Ellenberg?
Yes.
And Chairperson Simidian?
Aye. Motion carries unanimously, and without objection, hearing none, we are adjourned. Thank you all very much.
Thank you. Thanks, everybody.